Okay, we will be talking today, inshallah, about palliative care for end-stage pulmonary disease. These are the objectives of the presentation. Um, I want to say that I will not be able to go through all types of lung disease. Okay, we'll be talking mainly about COPD, pulmonary arterial hypertension, cystic fibrosis. As you see from the picture on the right side, we have three types of lung disease. We have airway disease, we have lung tissue disease, and we have lung circulation disease. So we'll be starting with the COPD, or chronic obstructive pulmonary disease. COPD is characterized by airflow limitation that's usually progressive and associated with enhanced chronic inflammatory response in the airways and the lung to noxious particles or gases. At present, COPD is worldwide the seventh cause of years of life lost, the sixth cause of global years living with disability for women, and ninth cause of global years living with disability for men. Unfortunately, palliative care up to now is underutilized in COPD, especially end-stage COPD patients. And we're going to explain why in the next few slides here. This is basically a comparison between the pink puffer and blue bloaters, or basically emphysema and bronchial inflammation. Just basic physiology here. Um, if you look at the distribution of adults in need of palliative care at end of life, you'll notice cardiovascular disease and cancer on the top, followed by COPD here. So it really, is considered the third cause of, palliative care consultations. So why we're having a problem with COPD as far as palliative setting here? The reason is the prognostication is much more difficult than cancer patients. In cancer, the patient, deteriorates very slowly, and then all of a sudden will drop at the end. While in COPD, they go up and down, as far as their trajectory goes. So it's kind of difficult to determine, whether the patient has less than 6 months or not. And you can see that all the time in the, ER. A patient with COPD comes with exacerbation. He cannot breathe. He's, cyanosed, and all of that stuff. He gets the steroids, bronchodilators, and then he will, turn 180 degrees, and he will look like, nothing had happened here. So this makes it very difficult for us to prognosticate, these folks here. This is what we're talking about, the COPD trajectory. Look at how it looks like. But I want to say that every time the patient gets an exacerbation, he drops a little bit. He goes home, he doesn't go back to the baseline. He looks like it, but he doesn't. He keeps deteriorating slowly as time goes by here. These are the recommended, progression of COPD pharmacotherapy. And basically depends on the forced effective volume 1. All right. you can determine whether this is a mild, a moderate, severe, or very severe, and whether you need to add steroids or not. You need to add long-acting bronchodilators or not. Prognostication of COPD is like anything else, is composed of two categories: the foreseeing or estimating the prognosis, and foretelling, discussing the prognosis. We will talk a little bit today about the actuarial estimation of survival, which depends on mathematical calculations, basically. So one of the important screening, scores is the Glasgow Prognostic Score, and actually this was, initially found to be useful in non-small cell lung carcinoma. And basically, it's a screening test. So it's useful early on, and it's very easy to use because you basically check two items here: the CRP and the serum albumin. Another score that's extremely useful in chronic COPD patients is the body index scoring, which relies on four factors: the FEV1, the walk distance in 6 minutes, the MMRC, which is the Modified Medical Research Council, and the body mass index. Okay. Now, with the body mass index, I want you to, notice something. If you're above 21, you have a better prognosis. Okay. If you're less than 21, you have worse prognosis. Now, as far as FEV1, if it's less than 3, if it's less than 35, you basically are on the 3 level here, which is the maximum. Also, the walk distance, if it's less than 149 or 150, you're at the 3 level here. The MMRC dyspnea scale is from 1 to 4, 4 being the worst. The body index can give you a 12 and 24 and 52 months, basically mortality rate. Okay. Be careful about this, because sometimes when we describe these prognostic scales, sometimes we mention survival scale, and sometimes we, describe mortality scale. So be careful, because they're basically opposite to each other. This is basically the MMRC, 4 from 0 to 4, 4 being the worst. The 6-minute walk test is commonly used test for objective assessment of functional exercise capacity. I would consider it as basically as a simple exercise test, like the one that you do for the heart, but without any equipment, basically. Okay, you ask the patient to walk for 30 minutes in a corridor, and basically, uh, you know, uh, 30 meters, walk 30 meters, in a corridor for a period of 6 minutes. Okay, and then you can measure basically how much the patient, walked. So a very useful test for these kind of conditions here. All right, so this is basically it. Okay, the distance is 30 meters. You go back and forward, and in 6 minutes you can determine how much the patient had walked. Hospice eligibility in COPD patients. All right, It's, as I said, it's much more difficult than cancer patients. But basically, you refer the patient for hospice. If you have a disabling dyspnea at first, little or no response to bronchodilators, decreased functional capacity, and two, progression of the disease, as evidenced by recent history of increased office, home, or emergency room visits or hospitalizations for pulmonary infection or respiratory failure. And number three is documentation within the past 3 months, hypoxemia on the at rest, on room air, PO2 less than 55, or oxygen saturation less than 88, or hypercapnia, with PCO2 of above 50 millimeter mercury. Um, with advanced care planning, palliative care is now an important field for these advanced COPD patients, because you can basically help out, with the symptom management, like dyspnea, fatigue, pain, depression, psychosocial distress. But again, it's still, underutilized in COPD patients, palliative care, not like cancer, and even not like a cardiovascular disease. So again, the reason is uh, where the palliative care services are underutilized is the distinction between curative and palliative. When do we switch from being curative to palliative? This is basically the most difficult part of the equation here in COPD patients. COPD is a systemic inflammatory, a disease. It affects your whole body. It can cause peptic ulceration, osteoporosis, depression, cancer, angina, coronary artery disease, and diabetes, and metabolic syndrome. Symptom burden in COPD: dyspnea, fatigue, anxiety, depression, anorexia, cachexia, edema, pain, care dependency, and impaired quality of life. And this is just a basic information comparing the restrictive versus obstructive lung disease here. So we're going to talk about some of these symptom burden. The most important one is dyspnea, or what we call breathlessness. The definition has been divided recently into breakthrough and episodic. I want to say that the episodic is more common, than the continuous, almost 60%. Now, you can have both the breakthrough or the episodic and the continuous together, and this is around 20%. Then you have another definition, which is the refractory dyspnea, which is the dyspnea that's characterized by difficulty breathing, persisting at rest, or with minimal exertion, despite optimal therapy. And then another definition, dyspnea crisis, which is defined as the sustained and severe resting breathing discomfort that occurs in patients with advanced, often life-limiting illness, and overwhelms the patient and caregiver's ability to achieve symptom relief. A dyspnea crisis is a medical and palliative emergency. Patient needs to be admitted to the unit. How to manage dyspnea? First, try to treat the cause. Okay, and there's a mnemonic for it: the bronchospasm, the valves, effusion, airway obstruction, secretions, and low hemoglobin. Okay, we call it breathe. So sometimes you need tracheostomy, sometimes you need a stent, and so forth. There's another way of thinking about the dyspnea here is what we call the breathing, thinking, functioning model. Okay, this is a very important model in dealing with dyspnea here, which basically, gets us to, uh, you know, uh, an important issue that dyspnea is not only a physical problem. It's a psychosocial problem, like pain. Okay, there is total, uh, uh, dyspnea, like total pain here. There's a element organic element, and there's a psychogenic element. Okay, one of the important management we use in dyspnea, and it's very simple to use, is what we call handheld fan. Okay, so this is something that we encourage the patients to buy and to use. It has some effect on, when you direct it to your face, it kind of goes like a reflex, relaxation, of this breathlessness, okay, through stimulation of the trigeminal nerve, available everywhere, you know, and it's pretty cheap to buy. Opioids. Opioids should be, your last resort, not the first resort. First, try to treat the dyspnea itself, and then if doesn't work, you can add a small amounts of opioids. And opioids basically dampen this pre-Bozinger complex here. All right, and this basically knocks off the air hunger the patient has when he gets the dyspnea. The doses that we use for dyspnea is much lower than pain, and this is just an example. All right, for morphine, hydromorphone, or fentanyl. Another non-pharmacologic technique is acupuncture. And it's been shown that it helps with dyspnea. The most famous points are called the anxiety, stress, and dyspnea points, basically the points on the front of the manubrium. By the way, I ask the patients to, rub their manubrium here gently, okay, when they get stressed or dyspneic. It really helps. I mean, you can, even patients with who gets heart attack, you know, reflexly they will start massaging their manubrium here. Another point that I found very useful is called the infraspinatus trigger point. It's a trigger point in the middle of the infraspinatus muscle. And these folks, when they used to come to my clinic, I used to inject it with some lidocaine. I used even because most of them they're very skinny. So I used to use a very small, tiny needle, the one we use for insulin injection. It's like a half an inch, so we don't get pneumothorax or anything. And you inject, basically, you kind of palpate underneath the spinous process and inject a couple of cc's of lidocaine in the trigger points. It gives an immediate relief of the dyspnea, but of course, it comes back later on, but patients feel pretty good after, he's been injected. And so you can ask him to rub this area whenever he's uh, having problem here, or somebody else can rub it for him. Physical exercise, and one of the most important things is what we call first lip breathing, sitting forward, diaphragmatic breathing, blowing as you go, and pacing your breathing. These are very important instructions that you should teach your patients about. This is like, pursed lip breathing, all right? It creates something like CPAP to these folks, and this helps with their breathing basically. Diaphragmatic breathing is to ask the patient to put their hands on their abdomen and try to inflate their abdomen uh, you know, um, as they breathe. This will help with their, uh, you know, breathing and anxiety in the same time. Our breathing control, what we call 3-2-4. Again, same concept. Breathe through your nose and breathe out through your mouth. Mobility aids are very useful in these folks, you might utilize something like that, to help out the patient walking, okay, and so he can get out of the bed and move his, limbs, and this will help his breathing. Uh, Pulmonary rehabilitation, you can send the patient for pulmonary rehab, use something like incentive spirometry. Another problem is fatigue. It's very common, mental and physical fatigue. Um, and, there are so many factors that can lead to fatigue. These are just some of them, okay? And the treatment of fatigue could be pharmacological or non-pharmacological. You know, I want to say something, guys, about fatigue. Fatigue could be even worse than pain. All right. I mean, fatigue is very debilitating symptom, and it's very difficult to deal with. The most important thing is the steroids. But steroids comes with its price, as you know, with all kind of side effects. So we try to use non-pharmacological techniques. Uh, I use omega-3 fatty acids. I use American ginseng sometimes. Coenzyme Q10. These kind of treatments that will not cause a lot of side effects like steroids. But steroids still has the most important impact as far as fatigue. Anorexia cachexia syndrome, is another problem that we encounter with COPD patients. And as you know, most of these guys, they're very skinny. And actually, if their body mass index is less 21, this is a bad prognostic sign here. As you can see, the commonest four causes of anorexia cachexia is cancer, CHF, COPD, and end-stage renal disease. One of the things that have been shown to be very useful, and there's a lot of investigations about it, is ghrelin. Ghrelin has been shown to cause significant increase in the mean body weight as an appetite stimulator in COPD patients. Again, the number of persons in the United States with cachexia, look at the COPD patients, about 20%. 20% has cachexia. These are the medications, pharmacologic therapies we use. As I said, on the top of the list is like fatigue, is steroids. Okay, but you have ghrelin, you have dronabinol, Megace, but all of these, the evidence is mainly for steroids. Pain and COPD. Chronic pain is common, and it's under-recognized and under-treated in COPD. It's estimated to be from 32 to 60%. There is total pain. There is old age, problems with like osteoarthritis and other comorbidities. Pain in COPD patients impair quality of life, sleep, causes anxiety and depression. And it's associated with higher dyspnea. So the more dyspnea you have, the more pain you will have, and also depression and lower physical activity. Total pain is, again, a term coined by Cecil Saunders for physical and non-physical causes of pain. Okay, we'll jump into another condition, which is pulmonary hypertension. It's pulmonary hypertension, by definition, is defined as the mean pulmonary artery pressure, mean, not systolic, not diastolic, mean. Mean pulmonary artery pressure above 25, as measured by right heart catheterization. Also, you can divide it like the New York Heart Association classification from grade 1 to 4. The WHO has a classification, for pulmonary arterial hypertension. We're going to show it to you. But I want to mention an important issue. There is something called pulmonary arterial hypertension, and there's something called pulmonary hypertension. Pulmonary arterial hypertension is one type of pulmonary hypertension, okay? And this one is characterized by increase in the pulmonary vascular resistance. And this is basically the WHO classification. This is the first category is the pulmonary arterial hypertension. The rest of them, 2, 3, 4, and 5, are called pulmonary hypertension alone. There is no arterial here, okay? So this category is so important, despite it's not very common. There's idiopathic form, which is around 50% of pulmonary arterial hypertension. There is also heritable causes. Drugs like amphetamines can cause pulmonary arterial hypertension. Also connective tissue disease, HIV, schistosomiasis for the guys in Egypt here. This is a very common parasitic infection. Then you have pulmonary hypertension due to left heart disease. Now, this is not arterial, again. And this is very common. Actually, this is the commonest type because of the, heart disease is so common. And then you have ones related to lung disease or hypoxemia, ones related to thromboembolic hypertension, and then miscellaneous causes of pulmonary hypertension. Again, this is the WHO classification of pulmonary hypertension. You should be aware of it. Okay, the investigation starts with EKG, chest X-ray, Doppler, right heart catheterization, and others. Management, diuretics, supplemental oxygen, anticoagulation, digoxin to control the atrial tachyarrhythmias. Then you start with vasodilators like prostacyclins, agents that block endothelin mediated vasoconstriction, and agents that enhances nitric oxide vasodilatation, like sildenafil and others. Now, calcium channel blockers play a very important role for patients that have what we call positive reactivity test. And then at the end, you can do lung transplantation and pulmonary thromboendarterectomy for patients with thromboembolic hypertension, atrial septicectomy. Another procedure can be done for the pulmonary hypertension. Again, this is the different vasodilators we use. Either you release nitric oxide or block endothelin or stimulate the prostacyclin. And this is an algorithm for pulmonary hypertension, atrial septicectomy. Okay, the reason we do this is to improve the hemodynamics in patients with pulmonary hypertension. Uh, Pulmonary thromboendarterectomy. This is a very complicated procedure. It's done under bypass, and they open up the pulmonary artery and remove the blood clots, as you see here in this picture. Lung transplantation is the final, pathway. Cystic fibrosis, maybe it's not common in Middle East. It's very common in the in the Western Hemisphere. I remember we in our hospital we used to have a team taking care of cystic fibrosis and another team for patients with sickle cell disease, because we have a lot of Afro Americans as well, uh, and we had the Caucasians. They get the cystic fibrosis. It's an autosomal recessive disease. In a sense, it's very similar to bronchiectasis. Okay, and I want to say that there's been a huge improvement. Nowadays, the survival of a patient with cystic fibrosis is above 50 years. So this is really a very important thing to know. Palliative care plays a very important role because these guys, they get a lot of comorbidities like diabetes, pancreatic insufficiency, fat malabsorption, hepatobiliary disease, and others. Again, we don't have a specific, a scale to prognosticate for cystic fibrosis, like we do have for COPD, like the Body scale. But we have important parameters for, lung transplantation. All right, but these are basically, the prognostic factors for cystic fiber, kind of similar somewhat to the Body scale, but it's nobody came out with a specific scale for cystic fibrosis patients. Okay, this is basically the criteria for lung transplantation. So you need to be aware of it. Okay, FEV1 less than 30, exacerbation of pulmonary disease requiring ICU stay, and so forth. Increasing frequency of exacerbations requiring antibiotic therapy, refractory or recurrent pneumothorax, recurrent hemoptysis not controlled by embolism. Okay, I'm going to end the presentation with talk a little bit about oxygen therapy. Okay, so we have different types like nasal cannula, simple fast face mask, the Venturi, non-rebreather, and the high flow oxygen nasal cannula. With this one, this is, kind of new, sort of recent, and with this one, you get a flow of about 30 to 60 liters per minute, and you can achieve 100% FiO2 with it. All right. Now, oxygen therapy in palliative setting is used for patients with who are mildly hypoxemic or non-hypoxemic patient with refractory breathlessness. So basically, you need to use it in hypoxemic patients, all right? But sometimes we use it in patients with refractory breathlessness because it helps with, exercise. Okay, it helps the patient to go around, sort of. So the patient can use it when he starts to walk around and all that. So this is useful. Nasal cannula, simple mask, Venturi mask, non-rebreather. Then we have the non-invasive respiratory support, uh, you know, um, like, for example, the CPAP, and this is used for type 1 respiratory failure, the one that characterized by hypoxemia, CPAP machine, um, ResMed, the most famous company doing CPAP. Basically, you apply the pressure here around the nose and the mouth, and this will, keep the alveoli open, upon expiration. There's another one called BiPAP. The BiPAP is mostly used for type 2 respiratory failure, where your CO2 is pretty high. All right. And this is from Respironics, and it's a BiPAP machine. And then you have the high flow nasal cannula, the one I mentioned before here. And this is useful for patients that failed CPAP and BiPAP. Okay. And it looks like this. It can give you up to 60 liters per minute. It's, a very powerful way to deliver oxygen. All right, so I have a nice picture for CPAP, BiPAP, high flow nasal cannula, the settings for each of them, and the indications. I want to mention something. As a palliative physician, you should know how to set up these machines, okay? Because you can get somebody from, the wards, and you call the respiratory therapist. He's gonna ask you about the settings, and there's no, shame to ask the therapist. To be honest with you, how to start the patient. But here it gives you some idea about it. Okay, the LTOT or long-term oxygen therapy, I just mentioned it here so you don't get confused with the rest of the oxygen therapy techniques here. This is not for palliative patients. This is for COPD patients, and it's been shown to improve, their survival. It can be used in other diseases as well, like cystic fibrosis and interstitial lung disease. Um, we can wrap up things here. Palliative care models have been designed for cancer patients, but are not a good fit for COPD, for which prognosis is more uncertain, and the distinction between curative and palliative therapies